Neuroendoscopy Intracranial, for placement or replacement of ventricular catheter and attachment to shunt system or external drainage. The physician inserts the neuroendoscope into the ventricular compartment of the brain through a burr hole in the skull just big enough to allow passage of the instrument. The scope works within the fluid-filled spaces of the ventricles and gives a much better visualization of the intracranial anatomy to allow the choroid plexus to be seen at the time of shunt placement. After the choroid plexus and ventricular anatomy are identified, the neuroendoscope is removed and the ventricular catheter is placed at a specific distance in front of and above the choroid plexus. The positioning above this potentially obstructive tissue improves shunt success since catheters placed in this position using the neuroendoscope require fewer shunt revisions and there is no need for a second pass through the brain parenchyma. Neuroendoscopy Intracranial, with dissection of adhesions, fenestration of septum pellucidum or intraventricular cysts, including placement, replacement, or removal of ventricular catheter. A small incision is made in the scalp based on the location of the cyst and a small burr hole is made in the skull just big enough to allow passage of the instrument. From this point, the scope is inserted into the cyst within the ventricle and the wall of the cyst is fenestrated, or opened, to drain the cystic fluid into one of the natural fluid chambers of the brain where it can be absorbed naturally. This is done by the use of a laser micro-contact fiber inserted through the endoscope within the ventricular cannula. In this way, cystic adhesions within the ventricles can also be dissected as well as fenestration of the septum pellucidum, the membrane separating the horns of the lateral ventricles, for cyst drainage. This code includes placement, replacement, or removal of a ventricular catheter. Neuroendoscopy Intracranial, with fenestration or excision of colloid cyst, including placement of external ventricular catheter for drainage. With retrieval of foreign body. The physician uses a neuroendoscope for intracranial fenestration or excision of a colloid cyst. A colloid cyst is a benign tumor in the third ventricle that contains a fluid of jelly-like substance. A small incision is made in the scalp behind the hairline and a small burr hole is made in the skull just big enough to allow passage of the instrument. From this point, the scope is inserted within the third ventricle and navigated to the tumor. The wall of the tumor is coagulated with electrical current and fenestrated, or opened, with sharp dissection. Suction catheters are used to empty the contents and the wall is excised. Any remaining tissue is destroyed with electrical current and the endoscope is removed. This code includes the placement of an external ventricular catheter for drainage. Report 62163 if the neuroendoscope is inserted in a similar procedure and used to locate and retrieve an intracranial foreign body. Neuroendoscopy Intracranial, with excision of brain tumor, including placement of external ventricular catheter for drainage. A small incision is made in the scalp based on the location of the tumor and a small burr hole is made in the skull just big enough to allow passage of the instrument. The scope is inserted into the ventricular compartment and moved to the tumor site. Many brain tumors occur situated deep within the brain in the ventricles. The neuroendoscope works with clarity within the fluid-filled spaces of the ventricles. The tumor is easily identified because of the different tissue appearance and is resected and removed completely through the endoscope under direct vision. Using the neuroendoscope allows bleeding vessels to be seen and other important tissue within the ventricle to be avoided and eliminates the need for long scalp incisions, skull flaps, and dissection through brain tissue. This code includes the placement of an external ventricular catheter for drainage. Neuroendoscopy Intracranial, with excision of pituitary tumor, Trans-Nasal or Trans-Sphenoidal approach. The physician excises a pituitary tumor using neuroendoscopic techniques employed transnasally or transsphenoidally. The face and nostrils are prepped as well as the abdomen, in case a fat graft must be harvested. Vasoconstriction is achieved in the nasal mucosa and blunt dissection is used on the middle turbinate to view the uncinate process, which is removed with rongeurs. A complete ethmoidectomy is done with removal of the posterior half of the middle turbinate. A Freer elevator is used to identify the sphenoid sinus ostia behind the posterior ethmoid wall, and the ostium is enlarged with pituitary rongeurs. The sphenoid anterior wall is removed for insertion of the endoscope. The sinus mucosa is removed with rongeurs and blunt dissection to expose the posterior sphenoid sinus wall and the sella floor. The pituitary fossa is entered and the sella floor is opened with an osteotome, if possible, or small, high-speed drills. The dura is coagulated with bipolar cautery and an incision is made. The tumor can now be removed with suction and angled curettes. The scope is advanced into the empty pituitary fossa as the tumor is removed to check for complete resection with the assistance of angled telescopes. Hemostasis is ensured after tumor removal. If cerebrospinal fluid is seen, the sella is packed with a fat graft harvested from the abdomen. The instruments are removed and no nasal packing is required.